Good afternoon. I'm Dr. Doug Evans, Chair of the Department of Surgery at the Medical College of Wisconsin, and welcome to our weekly update on innovations in the Department of Surgery. Today I'm really fortunate to be joined by Dr. Harveshp Mogal, and Harveshp, thank you so much for joining us. Harveshp completed his surgical oncology training at Wake Forest University, where he developed a specific interest and really special expertise in the topic of our video today, and that is HIPEC, and we'll explain what that is in more detail. Importantly, Dr. Mogal is completely trained in surgical oncology. His practice involves the gamut of solid organ cancer surgery, but his area of special expertise, academic interest, and where he hopes to make a real impact for the patients of tomorrow is in the area of HIPEC. He's been with our department now for over 1 year, coming from Wake Forest. And Harveshp, maybe we could start by a description of what HIPEC is. I know that those patients who are contemplating this operation on them already have a little bit of a background, but maybe for the general audience who will be watching this video, you can talk about
Sure.
this.
So HIPEC stands for Heated or Hyperthermic Intraperitoneal Chemotherapy. There are some patients with abdominal cancers in whom the cancer has spread beyond the organ of origin to the lining of the abdominal cavity, also called the peritoneum. When that happens and the cancer is restricted to the peritoneum and has not spread to any other part of the body, there are therapies we can offer these patients, specifically surgical therapies, to potentially offer them long-term disease control and in some cases even cure. And HIPEC is one of those therapies. The procedure in essence has two components. The first part of the operation, also called the cytoreduction, is where as the surgeon we go in and we remove all the visible disease surgically, and that may mean removing part of the organ or just stripping the lining of the abdominal cavity, also called the peritoneum.
Let me just stop you just to clarify. So this operation is appropriate for patients whose cancer has spread throughout their abdomen.
Correct.
Right, and it seems to be unique to a few more common etiologies. In other words, the cancer, for example, breast cancer isn't really amenable to this. Pancreas cancer usually isn't.
Correct.
Lung cancer would be uncommon. So what are the cancers that most frequently give rise to this type of recurrence?
So usually it's for appendiceal cancer or cancer coming out of the appendix. In some cases of colon cancer, we can offer this operation. Sure. In some cases of rectal cancer, we can offer this operation. We have done HIPEC in selected patients with stomach cancer or gastric cancer. Mesothelioma is a cancer that arises from the peritoneal cavity itself in patients that have had long-standing exposure to asbestos. Okay. It can be used in that. And in cases sometimes of ovarian cancer or cancers that arise from the ovary or the fallopian tube. Even though HIPEC traditionally has not been used for other cancers like breast cancer or pancreas cancer coming up from other parts of the abdominal cavity or outside the abdominal cavity, in rare instances, even in those cancers, we do offer HIPEC, not so much to cure their disease, but to offer them some symptom control, especially when they have excess fluid buildup that hasn't responded very well to traditional means like chemotherapy or medication. We can use HIPEC in select cases to prevent fluid buildup and improve patient quality of life.
And so it's safe to say that the most common indication would be cancer of the appendix or perhaps cancer of the colon and rectum.
Absolutely.
Kind of your two most common. And even though many people viewing this video may have never heard of cancer of the appendix, it certainly represents a large number of patients who seek their treatment with you, correct?
Yes, absolutely. And we know that the incidence of appendix cancer on the whole is on the rise. So a lot of patients are coming to see us for these therapies. And what's also different now compared to 20 years ago is 20 years ago, before we had this novel therapy, most patients who were diagnosed with this these kinds of cancers, with the cancer having spread throughout their entire abdominal cavity, were really not candidates for any kind of therapy. At that time, the approach was more often than not just symptom control. But now we know, because we have developed that expertise in this kind of surgery, that we can, if we can get patients to the point where we can do an operation and remove all their tumor in a safe and effective manner, that we can give them long-term disease control. So we're seeing a lot more patients being given the option of availing of these therapies that they never had 20 years ago. So we're seeing a lot of patients compared to...
And one of the big issues, of course, when the cancer in the abdomen gets so large, it's almost like they're pregnant, correct? And they're extremely uncomfortable all the time. And oftentimes, because the tumor is a little bit gelatinous, it is hard to be relieved with a catheter or anything else, as opposed to if it was just fluid, correct?
That's absolutely true. In fact, that raises a very important point, because a lot of patients who get diagnosed with this cancer get diagnosed in very late stages of the disease, when the cancer is spread throughout the entire abdominal cavity. And because it affects people sort of in their mid-40s or 50s, most of the time, because the disease process is somewhat indolent or slow-growing, most patients don't come to us until the disease is fairly extensive. But even in those situations, when that gelatinous substance has accumulated to a large extent, it's also called mucin. Yeah. We can offer them an operation where we are able to take all that mucin out, take the disease out, and then the second part of the operation is where we run the chemotherapy, the heated chemotherapy inside of the belly. And the reason we do the chemotherapy is whatever cells we can't see of the cancer, the microscopic cells that we haven't been able to remove, we hope that the chemotherapy will take care of those cells. And the heat helps the chemotherapy penetrate those cancer cells better. And we know that the operation combined with the heated chemotherapy offers patients long-term benefit in terms of minimizing the chances of a recurrence, as well as prolonging their life.
So maybe a few comments on exactly how this is done, because I think certainly the patients and their families would really appreciate this. So the initial part of the operation is straightforward. Make an incision, and you spend whatever time is needed, sometimes hours, to remove all of the tumor that you can find.
Correct.
And then after you're happy with the so-called cytoreduction, or getting the tumor down to as low a volume as possible, then maybe talk about what you do at that point.
At that point, once we've finished the cytoreduction, which, as you correctly pointed out, can last sometimes up to 7 to 8 hours, just to make sure that we've gotten all the tumor out, we then put specialized catheters or tubes within the abdomen, and those tubes are connected to a machine, also called a bypass machine or a pump. And through this machine, the chemotherapy solution is heated up. It enters the abdomen through those tubes. It circulates within the abdomen, circulates out through those tubes back into the machine, and then it goes back into the abdomen. So it's a closed circuit through which fluid continuously runs, and it's continuously maintained at a certain temperature.
And the patient's asleep this whole time?
The patient's completely under anesthesia. This is all part of the one big operation. And once the chemotherapy runs, usually for a duration of about an hour and a half, we then drain all the chemotherapy solution, and then we finish the operation.
Okay, and then at that point, you may have to put pieces of the intestine back together.
Correct.
You may have to sew things back together and then close the abdomen.
Correct.
So after the heated perfusion of the chemo is finished, usually the operation lasts a relatively brief period of time, right? You're nearing the end, if you will.
That's absolutely right. So once we've done the chemotherapy, really all we have to do is make sure everything looks good, and then we close the abdomen, and then the patient is awoken up from anesthesia.
And then typically watched in the intensive care unit most of the time?
Most of the time, our patients actually are able to be watched on the floor, which is the regular ward. In some patients, they have to spend a night or two in the intensive care unit, especially if they're a little elderly or if they have some medical problems that may need closer observation. But more often than not, our patients go to a specialized ward, 8 North. It's a specialized cancer ward that takes care of patients with cancer-related conditions and surgical conditions, where the nurses and the staff are very equipped to deal with patients like that.
How long does the patient usually stay in the hospital?
Our average length of stay is approximately 8 to 10 days, but I usually tell patients that their stay can be anywhere between 7 to 14 days, so anywhere from 1 to 2 weeks.
And it just takes a while for the gastrointestinal tract to work again, for them to be able to eat and
That's
drink
absolutely right.
and go home without an intravenous or any other supplemental support, correct?
Correct. Because of the extensive nature of the operation, the patient's bowels tend to be stunned for a while and don't tend to work as well. And so we just have to give them a little time for that to recover before they can eat and drink and go home.
Now, that it's well known that there aren't that many centers around the country that actually perform this procedure. Number one, because not everyone has a Dr. Mogal, which is probably the most important aspect to it, but also it requires a small village to really do all this. You briefly touched on the fact that there's a bypass machine similar to what is used in vascular and cardiac surgery that is used for the heated chemotherapy, but even before that, the whole programmatic infrastructure to allow for a global multidisciplinary management of the patient. HIPEC is just one aspect of care of the patient. Maybe you can touch on the village that you have developed here at the Medical College of Wisconsin that is so important to make this a program.
You're absolutely right. I think the key to remember with these operations is because of the complex nature of these cancers and the advanced nature of these cancers, we recommend that patients with this kind of disease are managed in patients that have a lot of experience, not only in terms of the individual personnel, like the surgeons or the medical oncologists, but also as a program. So not just individual, but programmatic experience. And even though there are a fair number of centers in the United States now that are offering this procedure, there are very few centers in the US that have a large volume of experience that has been accrued over a period of many years. Because we know that the more the experience, not only of the individuals, but also of the program and the center, the better the outcomes for our patients. And when you say, you're absolutely right when you say that the outcomes of these patients depends on the entire team being able to manage, right from the time our patients walk into our door to the time they have their first CT scan or MRI that is read by a radiologist that's trained to look for minute details within the abdomen that may not necessarily be picked up by a radiologist that doesn't see this disease very often. Similarly, our pathologists review slides on all of our patients, whether they've had a basic operation at another facility or their biopsy at another facility or they've had it here, because they have the experience to diagnose these kinds of fairly rare cancers. To the time when we actually discuss the patients in our multidisciplinary tumor boards, where all people, physicians and care providers from multiple specialties sit together and discuss the best approach forward. For instance, there are some cases of patients with some kinds of appendix or colon cancer where we initially recommend a brief period of systemic or IV chemotherapy before we undertake the big endeavor or the big HIPEC operation. To the time when we actually do the procedure and we manage these patients in the operating room, to the time when we manage them outside of the operating room after their procedures, because of the complex nature of the operation and the potential for complications, and to the follow-ups where we have to do scans every 3 to 6 months and look for subtle signs that the disease may have come back. I think every step of the way we need a team that's vested in the care of these patients, and not just vested, a team that's dedicated and experienced with the care of these patients so that we provide the best possible outcome.
I know it's tremendously comforting to the patients and their families when they go to, you mentioned 8 North Tower, which is the dedicated surgical oncology floor, and really has some incredibly talented nurses.
Absolutely.
But it's so comforting when the patient and family are greeted by a nurse who can relate to them that, oh, I've taken care of a huge number of patients after this operation, whether it be 30, 40, 50, and in some cases probably 100 patients who have had that operation. It just conveys that comfort to the patient, which is so critical to their recovery. What percentage of, if you take all of the patients that are referred to you, the medical oncologist, to various members of the HIPEC unit or team for possible hyperthermic intraperitoneal perfusion, what percent actually receive the procedure fairly soon thereafter, and what percent end up getting some other treatment before, after? In other words, that the global strategy seems to be changed a little bit.
Right. So our goal is to provide every patient that comes through our doors with a very balanced, personalized view of their particular disease condition. So two patients with appendix cancer, even though they may have the same kind of cancer, may have a completely different biology or disease process. And our goal is to provide that balanced approach. Sometimes it means giving them chemotherapy in advance, and sometimes it means taking patients up for surgery. Really, it kind of depends on the patient's situation. But I would say on an average, close to 50% of our patients get some form of chemotherapy, especially when you look at colon cancer combined with appendix cancer. And about 50% go to surgery directly when they meet with us.
Is it safe to say that virtually all patients with cancer of the appendix should probably see an expert like you, at least for a global review of the operation that's been done and whether any further treatment would be needed?
That's absolutely true. I recommend all our patients to have, again, a consultation in an institution with that experience like we have at Medical College of Wisconsin, because there are situations in which appendix cancers may not benefit at all from any kind of treatment. Most of the times they will benefit from surgical treatment, but sometimes they won't benefit from any IV chemotherapy. And there are situations where we do see patients who are getting IV chemotherapy with not a whole lot of benefit who are referred to us from other facilities. And I think the reason that happens is because this is a fairly rare cancer, and most institutions don't have the expertise or don't have the experience and haven't seen enough of this to be able to deal with it to make the best decision possible. And so many times when they come to us, we're able to guide them in the right direction because we have the expertise from not only the surgical perspective, but from other disciplines also, to be able to set forward a more comprehensive plan for further care.
One of the neat things about the work that you've done with appendiceal cancer or cancer of the appendix is that you have many patients who have done really well. So they've had a large operation, they've then had a HIPEC procedure, and they do well, and they and their families become advocates for the program. So you get a fair amount of press in the newspaper, on radio. Oftentimes you and your patients are featured at Miller Park, for example, before baseball games. And, you know, obviously a lot of those situations are showcasing success stories. How long did it take those patients to recover from the procedure? And you know, did they pretty much return back to normal? Can patients expect that, you know, in a certain period of time they can eat whatever they want, they can do whatever activities they want?
So most of the time our patients recover completely after surgery. The time duration that they take to actually reach that point differs. What happens many a times, because the operation is fairly extensive, is that initially patients seem to experience a minimal decline in their quality of life because of the fatigue and the tiredness and sometimes pain from surgery and the inability to eat normally. But this usually returns to their baseline in about 3 months. And what we have seen in more than 90% of patients is by 6 months, more than 95% of them have completely recovered and actually have an improved quality of life compared to what they had prior to surgery. So even though there is a small decline in the beginning, most patients recover it almost completely by the time they're a few months out from surgery.
Yeah, great.
And as far as the appreciation is concerned, you're absolutely right. Just to give you an example, we recently had a patient celebration event celebrating the power of HIPEC, and we had more than 250 patients with their family members who joined us at this event. Wow. at the Milwaukee Zoo, and it was incredible to see and hear some of our patients share their stories about their experience here at the Medical College of Wisconsin, and to see how they appreciate the fact that they have in their own backyards a facility that's world-class in terms of treating patients with this very specialized cancer that's not very commonly encountered, but they have the expertise that they can rely on to make sure that they're getting the best possible outcome. And we were extremely pleased by the turnout, and we thought the whole event was a resounding success. And we plan to have this every successive year so that our patients can not only share stories, but they can meet other patients in a similar situation or patients who are about to undergo the surgery so that they can have a resource for support.
Yeah, that's great.
And learn about the different upcoming challenges we're facing in the field and the advances we're making.
Wonderful. So to summarize, for potential patients, their families, loved ones, certainly a phone call to you or someone like you would be appropriate if they have any stage of appendix cancer, mesothelioma, and then probably work through their oncologist or their cancer surgeon if they may be a candidate for HIPEC with, say, stomach or gastric cancer, colon and rectal cancer,
absolutely,
and other rare diseases. Does that sound like a reasonable
That's
guideline?
perfectly. I think every patient with appendix and mesothelioma, appendix cancer and mesothelioma, should see a surgical oncologist that's specialized in HIPEC. And in select situations, patients with gastric cancer or colon cancer that has actually spread beyond the colon or the stomach into the abdominal cavity, based on how they're doing with their chemotherapy and based on recommendations from their medical oncologist, should also be given the chance to see a surgical oncologist to see if they are a good candidate for the HIPEC procedure.
Great. Well, Harveshp, thank you so much. Really wonderful to talk to you about this. I know this has been incredibly valuable for our audience. And for those of you watching today, Dr. Mogal's contact information will follow the conclusion of this video. Thank you again for your kind attention.